So as we discussed, we are finding the right patient, and to find the right candidate, we require now armamentarium tools, because all these different tools come into play in those minute fashions when you're looking at borderline corneas. And one such amazing tool is to look at the role of epithelial map with the help of OCT in our patients of refractive surgery. And to take us through this, we have Dr. Kumar, doctor, who has been at the forefront of refractive surgery. He is the past former member of the scientific committee of AIOS, the past president of IRSI, and he is going to take us through the epithelial mapping. Over to you, Dr. Kumar.
Good morning, everybody, and thank you, Vardhaman. I'm very happy with this hall audiovisual guys because they allowed me to use my laptop. I was struggling in hall 2, and it was a conversion to PowerPoint to something, and I was sweating from morning. But this is a good hall. So this is about epithelial mapping and refractive surgery. We have gone through a lot of things. Previously, we had ultrasound. Then we have Artemis coming through. Okay, why is this like this? Let me see.
Dr. Pradhan is here.
So again, that was another system where we used to look at the epithelial map. But now modalities have developed a lot. So we have to look at OCT-based and the anterior epithelial mapping. Luckily, we have Pooja in the hall who does a lot of epithelial mapping for everything and will correlate everything with everything. So that's a good news. But I'm just going to tell you my little experience because I've started LASIK in 1999. We never looked at the epithelium. And suddenly epithelium has become very important, and we'll tell you why. So this is just a modality that is nowadays available. Now look at challenges faced in refractive surgery. One is ectatic corneas, which we know that we can't do much about except all the other treatments like TREC or Intax or whatever you want to do, or a subclinical KC. So now we'll look at how epithelial mapping is going to change our looking at different things. So we have OCT-based devices which have a wavelength of 830, and it covers the central 6 millimeters, and it also looks at anterior-posterior curvature and the power. And of course, it's repeatable and it's reliable. So it's important to screen now every refractive patient for epithelial thickness, and I'll tell you why. The corneal epithelium can mask irregularities of the cornea, and it's important to analyze whether it's pre-ectatic cornea while planning refractive surgery. So in the diagnostic checklist now, it's very important to include, of course, topography has to be done, ocular wavefront analysis has to be done, dilated acceptance, all those things have to be done. We are looking at the stroma most of the times, but we are forgetting the epithelium, because the epithelium many times masks irregularities or causes irregularities, and that can cause a complete change in your result of refractive outcome. So this is a simple case, very straightforward. You can see a good epithelial thickness, 56, 55, all over uniform, and everything is fine. So these patients are good. So role of epithelial thickness mapping is very, very important in post-refractive surgery. Sometimes a patient comes back after 5 years, 6 years, and you feel that the number has regressed. So previously the patient was -6, they come back with a -2. You may look at the cataract, but there is no cataract, then you have to look at the epithelium. Especially if the patient has undergone hyperopic LASIK, where we are not ablating the center, we are ablating the periphery. There may be an apical syndrome. The topography, the corneal thickness has to be looked at when we are trying to do a retreatment. And of course, direct measurements of the epithelium is nowadays possible with all the technology that we have. So here we are just giving an example of the OCT thickness of the epithelium, which is all around, you can see is 59, inferior 64, which is seen on the OCT, and the anterior, which is also OCT based, where you can get almost the same reading of central 2 millimeter and 5 to 6 millimeter and 6 to 7 millimeter. So you can compare the two technologies which are there today. Now let's look at case number 1. So you can see there is an inferior steepening. I did get a bad D, and the patient wants to have LASIK. So then what did we do? We looked at the epithelium, and you can see that the epithelium is even all around, and we ruled out any subclinical ectasia. So remember that if the patient has anything like a keratoconus, there'll be an epithelial thinning in the area of the area of the keratoconus. Now let's look at case 2. Okay, here this is an abnormal looking superior steepening. again a bad D, and the patient wants refractive surgery. So a pentacam may create a doubt, and your 4 map may create a doubt. But again, we looked at the epithelium, and the epithelium was even all around, and the patient was fine, and the patient underwent surgery, and there was no other issue. Now let's look at case 3. Now, again, no red flags. Pachymetry is excellent, 546. But when you look at the posterior surface, you see a central red. So this actually, I used to panic when I used to see this posterior float, a red thing looking at you. Everything else is normal. You can see the Berlin ambrosio is going a little downwards. But one thing I learned from Rohit, and he told me, look at the white to white. So the white to white in this case was 10.5, and that's giving that red, which is in the center. So this one thing, don't get misled by just looking at the map and thinking that this could be a early form flux, but actually it's not. It's just that the white to white is small, and this is what happens in pentacam. And when we did epithelial mapping for this patient, it is absolutely even. So there's really nothing to worry, and this patient can go ahead and have whatever type of laser procedure you want to do. So this is one thing as far as the epithelium is, again, analyzing backwards, it helps you to analyze again. Now let's look at case 4. So here you can look at the anterior float. There is a suspicion of a steepening, okay? And the patient's vision is 6/9. So now the confusion is, what will you do? Okay, I'm not specifically saying, just presume that all the refractive errors are in the range of the pachymetry that is necessary for any refractive procedure for these patients. And that's the reason why we are not mentioning any refractive error here, because we are looking at the pachymetry, but remember that all of them are in the normal range. So again, we looked at the epithelial map, and you'll be surprised that the thickening is not in the area of the steepening. So again, this is a retrospective analysis that we realize that this is, again, a hypertrophy epithelium, not in the area of the steepening, and the vision is 6/9. So patient had surface irregularities, and that's the reason why the patient was given cyclomune, given lubricants, and then observed. So such patients, I may not go directly for a refractive surgery, just wait and watch, and see when the surface improves, recheck the epithelium, and then take a call what has to be done. Case number 5, 25-year-old. Now this is interesting, and I would like all the panelists, including Pooja, to look at it. That 25-year-old wanted refractive surgery, 3.5, 1.5. Everything else is normal. And this is the pre-op pachymetry and the map, 4 map, which is looking very good. And this is the other eye. So I did lenticule surgery for this, and the patient was extremely happy with one eye and unhappy with one eye. Okay? Unfortunately, I don't have the pentacam report, but I'll show you something very interesting. So this is the pre-op epithelium, okay? And this is the pre-op epithelium of the other eye. Don't forget, I'm doing lenticule surgery, okay? Now you'll say, why the hell are you bothered about the epithelium? But you'll be surprised what I see post-op and why the patient is unhappy. So this is again pre-op, everything looking good. 49, 47 may not be normal if you consider 55 as normal. And now let's look at post-op, okay? And look at this. So this is, of course, post-op. So this is what has happened post-op in the left eye. So I don't know whether any of you lenticule surgeons have seen anything on the epithelium after lenticule surgery, an unhappy patient. So there is some hypertrophy happening at the epithelial level. When I've done a lenticule surgery, I'll finish in a second. So I don't know, I would like comments from all of you whether you have done this, seen this, noted this, because I just realized why the patient was unhappy in one eye. And you see the surface, everything is good. I mean, the area of the stroma, very good, very smooth, no striae. We dilated, we checked on retroillumination, smooth, everything is fine. But patient is unhappy with one eye. So this is just a thought and an observation which you can take up. So in conclusion, now I think over the number of years, epithelium is very, very important. I think it should be a routine like doing a topography. You can customize your surgery according to the flap thickness. Of course, when you have to do a retreatment, please look at the epithelium because it will be hypertrophied sometimes, which gives a wrong result. And it can unmask stromal irregularities, important in ectasia prediction, and improve surface laser treatment. So for surface treatments, of course, epithelium thickness is very, very important. A lot of references, majority from Pooja, so can't help that. Thank you very much. Thank you.
Dr. Kumar, I'll just take one question till Dr. Pramod gets his presentation fixed. If a person has increased corneal epithelial thickness and you're going to do an enhancement for this patient.
Say that again, least.
The patient's epithelial thickness is more than normal and you're going to do, he has a residual refractive error and you're going to do enhancement. Would you prefer to do a PRK or you prefer to do a flap?
So, firstly, I would like to know the pre-op epithelial thickness. And if the epithelial thickness is really much more, it's better to just scrape off the epithelium, don't do anything. Let it regrow, remodel, and then see what happens. I will not do anything.
Rajesh, would you think differently?
Rajesh, you have to agree with me.
I think it depends on what degree of regression she is talking about. If it is only in the range of 0.75 to 1 diopter, then we know that even a 10 to 15 micron increase in epithelial thickness can produce this. Then I would agree with what he said, that we will debride that hypertrophic epithelium, let the epithelium become normal, and then look at the refraction again. Because if you were to go back and do a treatment for that, then you might create hyperopic shift for the patient later on. At the same thing, if you're treating trans-PRK for very low myopias, always pay attention to epithelial thickness map. I had done a trans-PRK for a 0.75 minus, and my patient came back with the same refractive error, minus.
Same refractive error.
And that was because his epithelial thickness was 65.
Yeah. No, what my thought was, it wasn't such a small residual. The patient had some minus 1.5 or something. Would I, and the patient, it's still early on, like hardly a year and a half since the primary procedure. So in those situations, I would lift the flap and treat, then play around with the epithelium is what I would do, and I wonder whether you concur with that.
No, if that fellow eye also has a similar thickness in epithelium, so that's the normal thickness of the epithelium for the patient, then it makes more sense to do a flap-based procedure.
Yeah.
But if the other eye epithelium is like 50, but this eye you got hypertrophy, then I would agree that we will
No, but then if you do again a PRK or anything, the epithelium is going to not heal less. The same issue is going to happen. So why not treat it
even to do a flap-based procedure, I would like to normalize the and then know how much to treat.
You can repeat measurements and check.
The SMILE procedure, that the lenticule procedure where you had irregular epithelium, one way to get over it is to do temporary punctal occlusion for the patient.
Dry eyes, yeah.
Because the dryness produces this kind of irregularity of the epithelium. So if you just plug the lower punctum with chromic catgut or a temporary plug, you will see improvement. Otherwise, you can even put a bandage contact lens for the patient and see, because that will also allow the epithelium to normalize, and then you can see whether that results in resolvement of the symptoms.
Right answers, yeah.
Thank you. Thank you so much.